Now, good afternoon, everybody. Now, we have some questions which Mr. Turner has. When you're ready, Mr. Turner.
Thank you, my Lord. Good afternoon. The first question I have received is for Professor Heyman. Professor, in your report, one of the lessons learned that you have is that the healthcare and social care sectors must build synergies for preparedness to ensure a surge capacity, making it possible to continue routine care while accommodating the surge of patients from the pandemic. Can you give an example of the synergies that the healthcare and social care sectors must build?
It's clear that in this pandemic, there were several factors which should be considered in the future. One of those is the failure of the public health system to be able to do the rapid investigations and contact tracing, effective contact tracing, and other activities that were required, possibly because they weren't decentralized enough. So the first thing that is required is a strong public health service. The second that's required is a strong clinical service, a service which can manage a surge of patients, but also at the same time manage those people who become ill but cannot receive routine care because the health service is blocked by either a shutdown or by the surge of patients from the epidemic or pandemic. And the third is that healthy populations resist better serious illness when they become infected. So what you end up with is three requirements for a really strong pandemic preparedness. That includes strong public health, surge capacity in health facilities, and effective health promotion that helps populations become more healthy, fewer comorbidities, and less serious illness. Those must work together. Clinicians, clinical doctors, for example, must be recommending to their patients the way that they can remain healthy and not develop obesity, other problems associated with obesity, such as diabetes, hypertension. And at the same time, the public health system must be contributing to that by providing the screening and other activities. So putting all of these three together from the basis, keep people healthy, keep hospitals functioning, and pull on the synergies of each other instead of having each one work independently.
Thank you very much. Professor Woolhouse, we talked at some length about cocooning and the approach and in particular its application in different circumstances. Could I ask you, we talked about the temporal period of time in terms of how long you might envisage cocooning taking place. Do you envisage any differences in approach to cocooning during the piece based on geography and circumstances of any given area? For example, do you consider that the approach to cocooning in any particular care home, for example, should be dependent on its specific circumstances and area?
Yes, I do. And in the later stages of 2020 and beyond, the Office for National Statistics was publishing very detailed data on the local distribution of cases, reported cases. You could go in and look at your own postcode and see what the local situation was where you were. And coming back to the many comments we've made about communities being at the heart of the response for this, obviously, all of us are interested in our own postcode. We're managing our risk not based on what's happening in London or Cardiff. We're managing our risk based on what's happening, in my case, in the outskirts of Edinburgh. And I think that helps everybody who's participating in a cocooning activity or any other way of managing the risk to themselves and others by understanding the local situation well. And those data were made available, and quite clearly people were interested in those data and acted upon them.
And in your view, therefore, would that mean that you could have care homes in different circumstances where the approach to, or the necessary approach to cocooning might differ, depending on those circumstances?
Yes, with care homes I prefer to call it biosecurity, but yes, I mean, the local prevalence of infection is clearly a marker of the pressure that the care home is facing, and it will want to respond to that. It's the difference between having a weather forecast for the whole of the UK and having a weather forecast for where you happen to be. That's much more helpful in telling you whether you need an umbrella or not than whether it's raining in London.
Thank you. I now have two related questions, which have been asked of Professors Gupta and Heyman. Professor Gupta, I'll ask you the questions first, and perhaps Professor Heyman, if you have anything to add or any distinctions you wish to draw, perhaps you could do that. Firstly, do you consider that lockdown in care homes should have continued if the measures in place were being undermined? And secondly, and related, if the lockdown was not continued, what do you anticipate would have been the impact of removing restrictions?
I think, I hope I've understood this correctly, because I wouldn't characterise or wish to characterise what should have been done in care homes as a part of lockdown, but rather as this sort of cocooning strategy. Now, obviously, in terms of protecting the vulnerable, one could argue, or it has been argued, that that's sort of just part of lockdown anyway, isn't it? And there is a subset of it that indeed is, which is relates to people who don't need cocooning per se, who should simply minimise their risk in a state-supported fashion, in ways that are available to them. But as we've discussed at length, what was needed in care homes was a more intensive solution, for which, I think we should still, it's a conversation that's in progress. What could we have done? As I was saying, I think it was very important, and one of the things we should have focused on at the outset was to try and maintain carers, a sort of standing crop of carers who were infection-free by whatever standards or whatever tools were available at the time. So at the start of the pandemic, it would simply be because they didn't have symptoms and had isolated themselves. Later, we had testing, which was very useful. What's important there is we needed to have a turnover there. You can't just take a bunch of people and say, okay, you've got to stay in isolation until this is over, and then we're going to pick you out to go and look after people. There has to be a sort of cycle there so that people aren't stuck in a particular state. And this is the dynamics of some of these smaller communities were somewhat overlooked. For example, even the vulnerable community, or the part of the population that's vulnerable, has a death rate and an influx. And, if you were not vulnerable when the pandemic started, and then you did not get infected, and then entered the vulnerable class in that period, your outcome could actually be worse. Now, fortunately, with the vaccine coming in, that no longer became an issue. But it's very important to recognise that these compartments are dynamic. People die, people become vulnerable, and similarly, among the carers, they can enter a situation where I would say, should be paid a lot of money to isolate themselves or keep themselves free of infection and be regularly tested. And then they would, in my sort of vision, they would go into the care homes, work there for a period of time, and then go back to their homes. So that's sort of what I think could be a solution. Obviously, there are other, I'm sure, far better, far more creative solutions to these problems, but whether they're implemented or not properly is nothing to do with lockdown per se. As Professor Woolhouse has argued, you can lock down or not, but still keep these measures definitely in place, or these processes. And I would argue that's what should have been done in January of 2020. That's the one thing we knew by then was an issue, and we should have thought hard about putting those measures in place. Withdrawal, how does lockdown interact? How does it, is it entirely independent of lockdown, or is there a relationship? Well, if you think that lockdowns do reduce the prevalence in the community, you might argue, I think it's a weak argument, that having a lockdown makes it easier to cocoon people. But what is much more important, I think, is knowing the state of the pandemic. So knowing whether we're in a wave or a trough, and which is exactly what Professor Wallace was just talking about, having the weather forecast, detailed weather forecast, is really important. But having a detailed weather forecast is a different matter to thinking that you can control the weather. And that's, I think, where the confusion arises. So we need to know as much as possible about the state, particularly the local state, how much infection is there, how much immunity there is. This is something that I was pushing in March 2020. Can we find out how much immunity there is? In fact, we developed a test in my lab to look at what are called neutralizing antibodies against COVID. It was incredibly difficult to get any samples. In the end, we looked at some Scottish blood donors, which gave us the answer that with that test, that at least 11% of the population in Glasgow had been exposed, but very little exposure, very, very low rates in Edinburgh. So, but we could not perform that exercise in our lab. We simply weren't given the samples to look at what was going on in London. But there are papers, some of which are still not published, showing that, for example, in among healthcare workers in London, the seropositivity, as measured at certain time points, was as high as 45%. So, but again, this is another compartment from which you become seropositive, in other words, have antibodies, and then you lose them. So the dynamics of that compartment also needs to be considered. So just to end by saying that I think that you need a lot of information. In order to protect people in care homes, we needed to know, as best we could, how far the epidemic had progressed, how much immunity there was in the population. So, for example, if someone was already immune, had antibodies at that stage, they may have been considered to be suitable carers, because at least for a short period of time they wouldn't be infectable. So this is what was required, rather than thinking about, or rather than hoping, what I call, again, trickle-down epidemiology, that somehow bringing the prevalence down in the population was automatically going to protect the vulnerable. I think that was a terrible error that we made, which probably resulted in more deaths than needed.
Thank you. Professor Eamon, I'll reiterate the question again for you. Do you consider that lockdown in care homes should have continued if measures in place were being undermined? And if the lockdown was not continued, what do you anticipate would have been the impact of removing restrictions?
Certainly the basis of the problem in healthcare and home care institutions was a lack of infection prevention and control. And that's the basis on which decisions need to be made. How can better infection prevention and control occur in care homes as it does in health facilities? Not lockdown of a facility or lockdown of the community. To do infection prevention and control, it's not a mystery. First of all, there are non-pharmaceutical interventions that are very effective in infection prevention and control. Hand washing of health workers or of carers, wearing of a mask to prevent others from being infected if one is infected. These are common practices which can be instituted everywhere immediately. Then, as time goes on and new innovations come in, such as testing, they can be incorporated. So to say that a lockdown, this blunt procedure, is necessary is the wrong way to approach it. The way to approach it is, what am I trying to accomplish? I'm trying to accomplish an environment where there's infection prevention and control. How do I do that? We know from hospital studies, from other studies, what works, what doesn't work. We need to institute that immediately, and then we need to, after that, have innovation that brings in other ideas, including ways that there can be safe visits to the people in those care homes.
Thank you. Professor Bambra, a question for you. There appears to be acceptance by all experts that non-pharmaceutical interventions, lockdowns, are likely to have a disproportionately severe impact on vulnerable members of society who can rely on social contact, routine and a range of medical and social support. From an epidemiology perspective, do you consider that there was or is sufficient data regarding the particular impact on vulnerable groups, and in particular people with profound and multiple learning difficulties, to have allowed for a robust balancing exercise to have been carried out when considering which NPIs or lockdown measures to apply?
Well, I certainly agree as one person that there were inequality impacts of the lockdown, and I've rehearsed some of those already over the last couple of days. When it comes to people with learning disabilities specifically, then obviously they did have one of the highest mortality rates from COVID-19. I think it was around 14 times the average. And again, there will be different reasons for that in terms of exposures as well as other factors, which means that they would then disproportionately benefit potentially from any of the MPIs. So it gets back to that trade-off that the lockdown or other restrictions might have negative impacts on certain groups. But in this case, you might say that that trade-off is acceptable because they are one of the high at-risk groups. But it may be that, for another example, that might not be the trade-off you would want to make.
Do you feel there is sufficient data to come to a view on that?
We know very little about the health of people with learning disabilities, and as Mark said, it was one of the more unexpected kind of groups to be having a vulnerability to COVID-19, and I would agree with that comment. There is a Learning Disabilities Observatory which does collect data and on the health of people with learning disabilities. But again, that's, I think, not as sufficient as it could be because of some of the data limitations that I've talked about within how we in the UK collect, including Scotland, collect our data, what we don't collect, and how we're reliant on things like the census, which does undercount multiple types of minority groups.
Thank you. Professor Heyman, at paragraph 6.21 of your response, you deal with non-pharmaceutical interventions in Scotland and state that other non-pharmaceutical interventions such as IPC with PPE, self-diagnosis and isolation, social distancing, outbreak investigation and interruption of sources of transmission, isolation of patients, contact tracing with isolation of those who developed symptoms, and shielding of vulnerable populations, including those in social care, were also justified and, together with lockdown, contributed to a decrease in the burden on the health care and social care systems. The questions following on from that are, do you consider that non-pharmaceutical interventions, and in particular lockdown, were effective in decreasing the burden on the healthcare and social care systems?
I think that early on in the, may I read this again?
Yes.
Yeah. And the question?
The question, and I'll put a proposition to it which may help as well. The question is, do you consider that NPIs, in particular lockdown, were effective in decreasing the burden on the healthcare and social care systems? And in particular, how would you respond to the proposition that there is no scientific evidence that lockdown was effective in interrupting or otherwise containing the spread of COVID-19, either by symptomatic or asymptomatic people?
I think it's very true that it can never be determined what was really the most important or the least important non-pharmaceutical intervention, because they were all done together. We talked about that previously, that to attribute to one intervention when there are many different interventions is very difficult, if not impossible, to sort out. So the justification came because there was fear that the health system was going to not be able to support what was going on in the communities as far as infection and disease. And therefore, initially, lockdown was a justified measure to try to attempt, along with other interventions, what might be most effective. However, in other countries, it was soon shown that there were areas where lockdown was not being useful or effective, and they were not incorporated in thinking in many countries, including in the UK. So together, all of these were contributing to decreasing a burden in the healthcare system, but I'm not able to tell you which was most effective or even if lockdown was effective at all, because they were all working together. My preference would be to begin non-pharmaceutical interventions in a public health manner which would not include the blunt tool of lockdown, but which would include other interventions. Lockdown would be very important very early in an outbreak when the transmissibility is not clearly understood. But in a respiratory infection, it's rapidly understood. And it was clear that lockdown could in no way interfere with the spread of this infection. It was a respiratory infection that could not be stopped by lockdown alone.
Thank you. Professor Wilhouse,
I might add, by lockdown alone, as might other infections which are transmitted through blood or blood contact with body secretions, there it may be that keeping those people in a sequestered area may in fact help in decreasing transmission.
Thank you. Professor Wilhouse, we spoke yesterday, indeed today, about messaging and voluntary compliance with non-pharmaceutical interventions. And we spoke about questions of trust and messaging and understanding of the public. Related to that, we've been asked a question, to what extent is the relationship between the public and those enforcing countermeasures, i.e. the police, a factor in compliance? This may not be a question that you can answer, I should say, but...
You need a card-carrying behavioural scientist to do justice to that question. I think one way trust is damaged is when it's easy to have the perception that what's being enforced is not reasonable or proportionate. So an example of that was solo hill walkers in Derbyshire being pursued by drones and given penalty notices when they descended from the hills. That's a pretty safe activity. So the police are being asked, or took it upon themselves, it seems to be unclear, to enforce a rule that actually isn't keeping anyone else safe. There's a slight counter-argument, you know, what if you broke a leg on the hill and the helicopter had to be sent off? But that's a very rare event. So again, there's no such thing as zero risk, I accept, but it has to be proportionate. And I think if the public gets the impression that the measures are simply not proportionate, then trust is challenged at the very least.
Related to that, and related to the issue, I suppose, of voluntary compliance, we're asked, in trying to greater understand behavioural fatigue, do you consider it would be relevant to explore the extent to which and the manner in which restrictions had to be enforced and how that may have changed over the duration?
Yes. The nearest we came to monitoring that, I got this on my computer once a week, was a survey of public attitudes around the pandemic and the response to the pandemic. And another thing I got on my desk every week was the results of behavioural studies that were showing what people were actually doing. And to be fair, the public were doing more or less what they said they were willing to do. And that did evolve through the course of the pandemic. So the most straightforward one was during the first lockdown, not surprisingly, and it probably wouldn't surprise anyone. In the early days and weeks of that, people were being very, very diligent. There were people disinfecting the tops of gates, outdoor gates, so that in case anyone else followed them through it. And that simply drifted off, even over the first week or two. People were still complying with the broad scope of the restrictions, but within that, they weren't disinfecting the parcels that the postman left at the door anymore. The behaviour changed as people's understanding of the risks changed. So that's always going to happen. I think it is very important to monitor it. And that includes, of course, and this wasn't done so well, monitoring compliance with necessary public health interventions such as reporting your test results and self-isolating when you need to. And that compliance was not perfect by any means. In Scotland, the surveillance turned up quite literally double the number of cases that were being reported. And the clear implication of that is an awful lot of people were probably infected but not reporting it. So that needs attention, and I thought that was a very big issue. We do need to pay attention to compliance and adherence with whatever regulations are in place.
Do you consider that, alongside public health agencies, the experience of Police Scotland and the Scottish Police Federation should be taken account in decision-making about non-pharmaceutical interventions, i.e. around the workability of regulations in terms of enforcement? Speaking
entirely as a member of the public on this, my instinctive answer is yes. I think you should consult before trying to enforce law, but I have no expertise in that area, I'm afraid.
There may be a similar answer to come, but would it be relevant as part of stress testing to consult on methods of ensuring compliance with lockdown, i.e. how policing of restrictions could be more effective from the public's perspective and also a police perspective?
So I infer on whose behalf these questions are coming, but I go back to my preference, as I think it's been echoed by some of the colleagues, that when it comes to, including the thing that I just said about reporting test results and complying with self-isolation, that actually take the police out of it. I prefer not to make these criminal activities. I think one of the biggest barriers, and I'm not the only person who thinks this, card-carrying human behavioural scientists do agree with me on this, the biggest barriers were people's ability to comply with the restrictions. And I don't think that should be criminalised. I think they should instead be supported in coming. So I would like to take the police out of the equation as much as possible.
Could I just come in and concur on that? I'm just thinking it through in terms of, if the police are having to implement measures, police measures, and also what that might mean in different communities where there could, for example, be distrust or tensions with the police, and then you're sending them in to check if whether someone's gone for too many walks or something like that. That would seem to be a very difficult thing for police officers to be asked to do, and I would agree that the evidence on compliance was very high, and then I'm not sure it would be very helpful to make it, to criminalise that kind of activity.
Thank you. You've mentioned the support available there, and you mentioned that in your report as well, Professor Woolhouse. What sort of systems of support do you envisage that might address breaches of regulation in the form of house parties or having too many people at a gathering?
Sure, that's a question of support. I think that's a question of people obeying the restrictions. But I'm going to respond to the question anyway. So one of the things the police did do in Edinburgh during the pandemic was break up a party of that kind. It took place in the Meadows, which, sorry for those who aren't Edinburgh residents, took place in the Meadows. It was students involved, and they were having one of those silent discos. So you actually wear a headpiece and the music is played through, and they were dancing in a socially distanced measure. And the police intervened. And I thought, what an imaginative way to get together socially and safely, outdoors, socially distanced, not even making a noise. And yet, the police intervened. So I think we do have to get the perspective right here. That was a very imaginative solution to the problem the students were facing, but it wasn't allowed.
Do you consider that criminal law has any role in the enforcement of public health restrictions? And if so, in what circumstances?
I've already passed on that question earlier on. You asked me whether, it was the same question I think, whether ever public health intervention should be mandated rather than voluntary, and I sat on the fence then, and I think I better stay firmly on it now.
That question may answer my next, which is, do you have any view on how restrictions were policed in Scotland during COVID-19?
I've just given you my view with the example of the... and I'm not, just to be absolutely clear, I'm not blaming the police in any way for that. I mean, they were doing the job that they felt they had to do. But there's a mismatch between the requirements that were given to them and how people are legitimately trying to do things safe, like walking solo in the hills or silent discos outdoors. There's got to be a balance there. In the early stages, there was such a low appetite for risk. So, can I tell you a brief story? That story about the silent disco, that was actually told to me by my neighbour. It was nothing to do with it. It was just a member of the public. And he said, this was during the second lockdown, and he said, during the first lockdown, I would have said, oh, no, that's wrong. You can't do that. He said, this time round, nah, good luck to them. People's attitude, and that was at the height of the alpha wave. I mean, that was a difficult time, but attitudes change as time passes, and they did.
Professor Heyman, in your written response at paragraph 6.25, you narrate that medical mask wearing with or without protection of the eyes does not provide full protection against infection of the wearer of the mask, and medical mask wearing by the general public to prevent others from becoming infected became controversial in some other parts of the world, where either public health or political leaders called it into question. Many times, as did WHO initially, they cited a lack of definitive scientific evidence about their value, but as evidence became available, it became clear to WHO that mask wearing by the general public was associated with a decreased risk of transmission. How would you respond to the proposition that face masks offered no significant protection? If I could put that in a wider context for you, Dr. Croft, as you know, has given evidence to the inquiry and made note of a Cochrane review and stated that, in other words, the updated Cochrane review continued to show that outside of healthcare settings, face masks offered no significant protection against acquiring respiratory illnesses from viruses, including SARS-CoV-2. Do you have any comment about that?
Yes, I think that in a household, if someone is infected and wearing a mask, they can in fact prevent infection of others if it's a respiratory infection of high transmissibility, if there's faithful wearing of the mask. But masking in the general population was not particularly useful outdoors, but indoors it was very useful in preventing transmission from people to others. Whether or not it can be proven, I can't say. I can only say that it's been proven that in health facilities, protection can occur when people wear masks to prevent others from getting infected. And that's why health workers do wear masks in many instances, including during surgery.
Thank you. Professor Bambra, at paragraph 7.3 of your response, you mentioned how specific information about community, rather than the individual vulnerability, needs to be considered and communicated effectively. How could you see this practically working out, verbatim, practically working out? For example, would it be desirable to have more regional health ambassadors who would assess and engage individual communities and regulating what happens in their area, as Sweden does? And are you referring to social, cultural, as well as geographical communities? If you'd like me to reiterate the question, I'm happy to do that.
Well, I'm just checking what I said. What I said was that providing information about community, not just individual vulnerability, needs to be provided. And so the question is, in a sense, how would that be done?
I think in essence, yes.
Yeah, and I think we have discussed some of this over the last couple of days. Obviously, there's the central messaging, then you could obviously regionally make that specific and cascade down. Definitely not just talking about geographical communities, also talking about cultural communities, and then we can think of more specific examples in terms of, for example, the work that public health does in terms of increasing screening in high-risk areas. That's or increasing vaccine uptake in in communities that aren't responding to taking up their invitation to take up the vaccine. So outreach work, that model, which might be similar to the Swedish model, I'm not familiar with that, but that method of outreach could be undertaken, be it, using means as the restrictions would enable. So, for example, obviously, if you're doing screening now, there are screening buses that go into communities to make access easier rather than people having to go to a hospital. Clearly, that might not be desirable within when you're dealing with a pandemic. So it might have to be through digital means, using cultural leaders, community leaders, to then cascade through their networks the messaging that you would want, and also to make sure that the messaging is made accessible in terms of languages and so on, but also culturally as well, in terms of being culturally sensitive and making specifics for where there might be issues in terms of, for example, people from British Asian communities are more likely to live in a multi-occupancy household. So it's more important that they get information specific to that to protect themselves and their community.
Thank you. Professor Woolhouse, in your response at paragraph 12.13, you suggest that perhaps government ministers are not qualified to make the types of decisions necessary to manage pandemics, and that job should be left to those that are experts, but that public health agencies are probably not currently up to the task. Can you give headlines regarding the type of changes that would need to be implemented to bring the health and public health agencies up to a level where they could take leadership in future pandemics? And would you recommend that they take leadership rather than elected government officials?
I think we've not got the part of my statement that says that exactly, so I'll just have to answer your question the way that you asked it. I think the easiest thing to point to, because you've heard so much evidence that this is the way it works in Sweden, which you've heard about and David summarised earlier today, where there is a different relationship clearly between the public health agencies and the government. And I think that is something that we could usefully aspire to in Scotland. I said earlier, I don't think we're at the point right now whether we could deliver an empowered public health agency along the lines of Sweden, but I think it's something that we should aspire to, yeah.
Thank you.
Sorry.
You can, yes?
Yeah, it's slightly related in the sense that one of the things that we noted when we did the report for the UK COVID inquiry was the impact that pre-pandemic policy, specifically austerity, had in terms of the public health workforce. So public health budgets in England were reduced by over 20%, and that particularly fell on more deprived areas. In Scotland, the Barnett formula meant that the Scottish overall envelope was also reduced, and that had knock-on effects in terms of Scotland's capacity within the healthcare and public health system as well. So that would also be something that needs to be thought about, is that it's not ideal to underfund public health in the run-up to a pandemic. I know we didn't know one was coming immediately, but there had been warnings that one was likely. So there we go.
I do agree with that, obviously, but the caveat is, in fact, in terms of preparing the pandemic preparedness of the sort we're talking about, in what the public health agency's plans are. The planning is not expensive. Planning is not that expensive. Implementation and building resilience of the health service as a whole is extremely costly, but the planning is not. So money's important, but it's not the only thing. You also need the right leadership and the right culture, as I said earlier. And I don't believe we have it in Scotland at present, but that's where we are now.
A question now that's been asked for the panel as a whole. Can you comment or give a view on the efficacy of working from home in relation to reducing the spread of the virus? Perhaps I can just go round, Professor Heyman, if I could start with you.
Working from home and a decrease in transmission?
Yes.
Working at home certainly is a way of decreasing transmission of an infection in the workplace. It's a no-brainer. The question is, what is the risk or what is the cost benefit of that, as opposed to going to the workplace and working in an area where there's also safe ventilation, adequate ventilation, safe distancing, and a better working together. It's a comparative analysis that must be done, as must be many analyses done after the pandemic is over, looking to see what has been best. Working at home has really changed the way we approach work today, and I think the long-term outcome of the impact on that is not yet known. But there will be an impact on working at home and continuing to work at home after the pandemic. And so all of these things must be measured as a part of what has occurred because of the pandemic. So working at home, yes, it was a way of decreasing transmission in the workplace. Was it really the most beneficial way of doing that is not clear.
Professor Gupta, have you anything to add?
I think the only thing we can be sure of is that working from home reduces your own individual risk. It's difficult, I think, to extrapolate from that to whether it would reduce transmission in the workplace, simply because it depends on the dynamics of the workplace. I mean, it could be that, and this will bring me to my next point, that because if nobody goes into the workplace, that's very clear, there won't be any transmission there. But if it's the case, which it is, that not everyone can work from home, then it's hard to, because as I said before, there isn't a simple linear relationship between who goes to the workplace and whether it becomes infected. We also haven't talked about environmental contamination, so I think it's difficult to, I would find it hard to say that it's clear that working from home would reduce infection in the workplace. I think what is obvious, and it must be true, is that if you work from home, you reduce your individual risk. But the most important, so the laptop classes, as we call them, were able to do that. Did they need to do that? Most of them, probably not. Some of them, absolutely. But the non-laptop classes could not do that. And so those among them who should have been isolated or working from home weren't given the opportunity to work from home. So there's another issue. When you work from home, you reduce your individual risk. You may reduce the risk of infection in the workplace. But what does that do to the economy as a whole? And whatever it does, and how does that take away from support that you might offer in your workplace to younger people, to the welfare of the economy as a whole? If you're not able to do certain tasks, it will become less productive. And also, if you work from home, reduce your individual risk and take furlough money for that, you're taking money away from people to protect yourself. And in many cases, I don't think that was necessary. And so I feel that working from home is a really important tool which should have been used to protect people who are at risk when they left home.
Thank you. Professor Woolhouse, any
It is, as has been said around this table before, very difficult when a substantial package of measures has been introduced to pick out the single contribution of one. The only example I can think where that's been done in really forensic detail is the effect of school closures, because that was so important. And that actually, on that occasion, showed that the contribution of schools to overall transmission was certainly manageable. It was low and definitely manageable. But colleagues are absolutely right to point out, therefore, that we don't really know how effective working from home was. But there's a danger there, because we don't know how, closing pubs, how effective was that? The travel bans that how effective was that? So, but overall, we do know that there was a reduction in transmission. So we can't remove all of them on the grounds we don't know whether they were effective or not without a negative effect. So you'd have to be careful with that, drawing too many conclusions, I think.
Thank you. Professor Bamber?
So I think that there would be a wider benefit than just to the individual who works from home, because obviously would then benefit your household and potentially any other community interactions that you might have, because you're obviously at lower risk, so therefore you don't have anything to pass on. I agree, though, that obviously only certain groups, certain occupations were able to work from home. But the counter would be if you had everyone or a lot of people continuing to go into the office, that would put a lot of interactions into the public transit system, which would then increase the transmission. So whether you think that's a good thing or not, I can't see how having more people in contact with each other wouldn't increase the transmission of a virus.
Professor Good.
Can I just quickly give an example of how that might not work? So if you think of your likelihood of being infected in a workplace as being proportionate to how many people are in the workplace who might be infected, then that argument holds. If your likelihood of being infected or not being infected is predicated on not acquiring an infection from anybody who enters that workplace, then it does not quite hold that, half the people not coming in is going to guarantee you half the protection that you think might accrue if you applied that logic to it. Since we don't actually know how transmission happens, and there's every indication that it's not, or that one of the reasons these restrictions don't show any relationship with prevalence, it is because it's not linear. It's not so simple. So, as I said, if everyone stays at home, of course, that's great. We know what that means. And if nobody stays at home, then what is supposed to happen happens. But we don't know how you get from one point to the other. And it's likely to be quite non-linear, which means that unless you get at least 90% people staying at home, you might have almost no effect on the spread, the transmission, and the risk to others, which would all still be not such a big deal, except for the fact that there is or can be a huge cost to the people staying at home idea, not perhaps to the individual who's staying at home, provided that they're properly supported. But, not staying at home means, staying at home means something beyond just you staying at home. In the case of our students, for example, us being told to stay at home meant that they didn't get the education that they deserved in those years. They didn't get the contacts. They were isolated. They didn't get the training. My daughter was at a law firm and training. She was supposed to be in an office being trained by people. She didn't get that. She had to do it remotely. Which is, in her case, not a big loss. But, we're talking when we think about young children, deprived children, not getting that instruction. We know what the consequences are, but we know now, we have data, but I find it hard to believe that we couldn't have anticipated that. So staying at home is a bit of a synecdoche in some ways for the actual effects that are attendant upon that.
So I'll just... but obviously we do know that transport workers were some of the people most impacted, particularly during the first wave. So obviously they were coming into contact with lots of people on a daily basis.
Is that why they were impacted, or is it because they had comorbidities and were, should not have been driving buses in the first place?
Well, I can't say I know enough about the comorbidities of bus drivers in Transport for London, but I suspect it's because they were highly exposed by the volume of people that they were in an enclosed
I have
seen
space. No data that supports the idea that, I'm sure there must be some dose dependence, but I've seen no evidence that amongst people who weren't vulnerable that dose dependence played a role in severity.
I was talking about exposure and transmission.
No,
but
exposure and severity. Well, we're talking about people getting ill, right?
well, I think the question was about transmission, but I'm happy to leave it.
My Lord, we are almost at break time. I do have two very short, hopefully, questions that will actually draw this section to an end, if I may.
Of course.
Professor Woolhouse, you referred to there being a reduction in NHS bed occupancy during the pandemic. Would you agree that looking at reductions in NHS bed occupancy is not wholly helpful in measuring overall demand in the NHS? For example, just because there is lower bed occupancy doesn't mean that the staff, particularly the nursing staff, are otherwise free or unoccupied themselves, as COVID patients, especially those in ICU, may need a greater ratio of professionals to patients than in other types of otherwise routine hospital or healthcare.
I actually do agree with that, and I think it's an opportunity to yet again compliment NHS staff on the job they did during the pandemic. It's not their fault that the beds were empty.
Thank you. And Professor Heyman, you mentioned, or we discussed very briefly, rates of transmission between children and teachers. Is there evidence that transmission rates from children to teachers differ at different stages? I.e., is there a progressive increase in transmissibility as children's age, or evidence of threshold points at particular developmental stages in terms of the rates of transmission?
I can't answer the question about progression. What I can answer is that after the primary education level and the age in the primary education, there was greater transmission within schools, and that occurred in secondary schools. Whether there's a progression, I would assume there probably might not be a progression, or there may be a progression. I don't want to speculate on that. What I would say is, if children have developed asymptomatic infection in primary schools, they would then not have the same problems that people who were naive and had no immunity in secondary schools were at the beginning of the pandemic.
Thank you. That, my Lord, draws an end to the questions that have been asked under Rule 9. What I propose to do now, my Lord, is to take our afternoon break, after which time I would propose to offer a brief opportunity for the panel to offer any final comments that they wish to make to your Lordship.
Indeed. We'll come back then at 3 o'clock.
All right.
Thank you. Right. Now, when you're ready, Mr. Turner.
My Lord, with apologies, my Lord, we have one final Rule 9 question. I almost made it through these series without lifting a piece of paper, but unfortunately I'm going to have to. Professor Woolhouse, could I ask, in a situation where cocooning was adopted, with or without lockdown being in place, do you consider care home residents ought to be isolated from each other?
So it's a good question. My own thinking was more of cocooning more in the concept of the community. And for a care home, the ideal is biosecurity. And basically, that you stop the virus getting into the care home at all, and that keeps that whole space safe for everyone. But I can see that in a large facility, in some circumstances, there may have to be some partitioning within that. I hadn't got as far in my thinking as to think whether individuals should be cocooned as if they would be in their houses. But the people who should manage this, of course, are the care home staff and leadership. And it comes back to the same thing. They should be empowered to do so. They should have the information, the knowledge, the understanding of how to control this virus, that they can manage their facility as they see fit.
Thank you. As I indicated before the break, what I'm going to do now is come round the table, if I may. I'm going to start with you, Professor Heyman, and give you the opportunity to raise any particular points that you wish to, that either you don't feel have been vocalised during the last 2 days, that you wish to particularly draw to His Lordship's attention, or potentially if there are any lessons that you think His Lordship should consider in terms of reporting, then please feel free to mention those. Professor Heyman.
Thank you. I think to begin with, it's very important to remember that when there's a new virus or bacteria in human populations, there's great uncertainty. And the goal of any activity very early on when an emergence occurs is, if possible, to stop it from becoming endemic, even though at that point of time it's not known whether or not it will become endemic. Once it's known, and this is in a very short period of time for a respiratory virus, in a matter of weeks rather than matter of months, once it's known that it is spreading easily among human populations and can in fact become endemic, then non-pharmaceutical interventions are very important to protect individuals, especially those who are most vulnerable. That may include precautionary measures, measures that might be modified after evidence comes in, but those measures are very important. The government has a very important role in this, in making an environment where communities and individuals are empowered to look out for their own health and the health of others in their own immediate areas. And at the same time, governments must facilitate and help lead the public health response to the outbreak. This involves many different interventions, including contact tracing. What needs to be done now in countries where there were lockdowns is to look at what happened from those lockdowns in many different ways, such as this inquiry, and also in scientific and academic publications, and to compare between countries. You've done an excellent job in bringing Sweden in, bringing in New Zealand to see what their activities were. What really are the best possible activities moving forward? They won't be the same for every country, but there will be a basis of those that are important. But what's most important is a strong public health institute that has the respect of the government to move ahead with the interventions that are evident, that are at the beginning precautionary and later on become evidence-based. Thank you.
Thank you very much. Professor Gupta.
First of all, I'd just like to thank you for the opportunity to have this conversation. It's been very valuable, and I hope it has had some value to your Lordship. I think that, much of what needs to be discussed has already been discussed, I think. In terms of focusing on particular issues. I would say that much of our role is really to define the uncertainties and to come up with a strategy that is as robust as possible to the uncertainties. Those uncertainties, of course, decline as we acquire more evidence, but it has to be acknowledged that, when we start off, we are faced with a lot of uncertainties. In some respects, of course, as I've said before, some of these uncertainties were weaponized, in my opinion, in ways that were unnecessary. So to say, for example, it was said that we didn't really know whether SARS-CoV-2 would generate any immunity at all, and that was really while of course that's not, we don't know until you see someone who's immune that this will happen. It was, one could make sensible inferences from our experience of the other coronaviruses. So it's important to be very clear about what we mean by uncertainty. At some level, of course, nothing is known until it happens, until the evidence is there. But, decision-making is all about operating in the absence of evidence, or trying to gather together such evidence as there is to put together a coherent picture. I do believe there was more certainty about the effects of some of these NPIs, which should have caused us right from the outset not to dismiss them, but to treat them with great caution and to think very carefully about the intent. What was the actual intent of putting stay-at-home orders in place? What were we actually doing? Could these measures actually bring down infection? If they did bring down transmission, to what end? What would that do? Would that actually reduce mortality? I think having a much clearer set of what we intend to do and how we might use what's at our disposal to affect that would be desirable. I think there was a lot of confusion about what we actually wanted to do and there was, to an extent, a blind acceptance, what I call the establishment of a doxa, which is always very dangerous because concerning what lockdowns were able to do. So we acquire knowledge as we go through these events, but it's very important to avoid the opposite of knowledge, which is doxa, so settled opinions in the absence of evidence on what certain NPIs or other measures to contain the pandemic might do. I think we're all agreed here what we really want to do was prevent those who are vulnerable to the severe outcomes of infection from suffering those. What we weren't mindful of, in my opinion, was the effects of those measures that we might bring in on other vulnerable categories. And so it's very important, again, to think about what does vulnerable mean, and how that we should, and as Professor Ambrose said, we must be very careful in clarifying, in declaring our terms, who is vulnerable to what. And finally, I think I'd just like to say something about the issue of responsibility, because I came into this, the reason I got involved in all of this is actually from the point of view of thinking that lockdowns themselves would cause enormous harm. And you might say that is not my professional expertise per se. My professional expertise would address some of the other issues. What was going to happen to how would the dynamics of the virus play out? How would it evolve? What was the likelihood that NPIs would contain it? And there I had some thoughts and ideas, and I tried to make a contribution. But fundamentally, I do believe that it's not good enough to say we are just scientists, we can only offer scientific evidence, and that's where our responsibility ends. I think that we all have to accept the responsibility and the of making recommendations on other factors than simply the science. And I hope that that's something that becomes part of the culture of policy making in the future.
Thank you. Professor Woolhouse.
I too would like to begin by thanking the inquiry for this opportunity to have this discussion. I think it's been immensely valuable. I think it would have been very valuable a few years ago in the midst of the pandemic. Nobody's fault here that that didn't happen, but it's a shame that these sorts of discussions didn't happen then. I'll summarise very briefly, but I will expand on a couple of points. The brief summary is I do not see lockdown as a public health policy. I see it as a failure of public health policy. Lockdown is what you do when all the other things you know you can do, should have planned to do, and should have the resources to do, you have failed to do. And you are then forced into a lockdown. So that we went into lockdown for me is a failure of public health policy in its sense. I'd also like to underline a point that's come up a few times, that the choice should never be framed as lockdown or nothing. And I hope that's become very clear by the discussions around this table, that there are always alternatives. We've discussed those at length, so I won't reiterate that now. But I will make an overriding suggestion of how you reach this point of finding alternative, and that is this. Make avoiding lockdown a government policy objective. Same way that avoiding huge numbers of deaths is obviously a policy objective, avoiding overwhelming the NHS is a policy objective, make avoiding lockdown a policy objective. Have it in your preparedness planning that that is what you're going to try and do. And what that would force governments to do is when they're asking advisors, and I completely agree that there should be a much wider breadth of expertise around the advisory table, is, well, Professor Woolhouse and colleagues, how would you do that? And as you've heard for the last 2 days, we would talk non-stop about how to do that. There would be plenty of stuff on the table, but we were never asked that by particularly UK government that really didn't want to go into lockdown. Well, advisors, scientists, how do we avoid doing that? And that didn't happen. So make it a policy objective. So that's not, unfortunately, the lesson that I think is being learned at other inquiries that are going on in the UK at the moment, which I've been very much involved in. We've had politicians, advisors, top scientists asked about, with hindsight, what they thought particularly about the March 2020 lockdown. And again and again and again, they gave the same answer. And Patrick, Lord Vallance, summed it up. He wants lockdowns to be earlier, stricter, wider, and longer. I actually agree with earlier, but we discussed that before. Now, given the harms that lockdown has done, is that the best that we can do with hindsight? Say we want more of it? That's absolutely extraordinary to me. That's an utter failure to learn the lessons from what happened. It's turning the thing about on its head. So I think that's a huge failure. As Sinead has pointed out several times, having this discussion actually was very hard in 2020. A journalist I know summed it up very well. He said at the time, supporting lockdown became a test of virtue. The implication was that if you didn't support lockdown, you were prepared for more people to die and you were a bad person. I hope this conversation has dispelled that notion utterly, but it was very prevalent in 2020. So that's important. As for why alternatives weren't adopted in 2020, I think we have to put a lot of the responsibility for that on the door of SAGE, the main scientific advisory group down south, who, again, as you've heard, were resistant to alternatives from myself, from Sinead, but also from anyone else to lockdown. They were very resistant to it. We weren't so resistant in Scotland, and as a result, we avoided at least one lockdown. My fear is nonetheless, despite this history, that in public health terms, lockdown has now become normalised. The genie's out of the bottle, and we won't go back to the place where this was almost an unthinkable intervention. It's going to be written up in textbooks. That's what the next generation of would-be public health practitioners are going to be taught about lockdown. I hope they're also taught about how to avoid it, and that's early action. It's the early action that's critical, and the way you get to the right early actions, and we discuss this much, is good situational awareness, particularly in those early stages. The most difficult phase of the next pandemic to navigate will be that first 100 days, when we don't have any kind of pharmaceutical interventions, so we're relying again on NPIs. So we need our NPIs, our non-pharmaceutical interventions, our plans to implement them, up and running, ready, not made up on the hoof as we did in 2020, but ready to go to meet this policy objective of avoiding having to go into lockdown. We need to do much, much better at that. And to achieve that, as I've said, we need public health agencies that are agile and forward-looking. That's tremendously important. And the final point is to make those NPIs work, because in the context of COVID and many other kinds of infection, though not all, it's public behaviour, people's behaviour that's going to determine the course of the epidemic. The system, that's us, needs to trust the public. And the public needs to trust the system.
Thank you. Professor Bamber.
Thank you, and I'd also like to thank His Lordship for enabling me to participate and to put forward some of the health inequalities aspects in this important debate about MPIs. So, in my closing comments here, I just want to sort of emphasise, I think, the main point that I've been trying to make at various points over the last couple of days, which is that the pandemic was very unequal and impacted on people differently. There were high structural health inequalities coming into the pandemic. During the pandemic, in terms of the impact of the virus on particular groups, post-pandemic in terms of things still like long COVID, there are inequalities within that. We've also saw inequalities in the effects of the MPIs and the various restrictions, both economically, socially, but also in terms of the health impacts. And I've talked, for example, about the inequalities in the mental health impacts of lockdown. So I think it's vital that we take better account of health inequalities and try to mitigate for them in future events in terms of planning, design, implementation and our monitoring. And so with that in mind, I made several recommendations in my written work for His Lordship. I will just emphasise 3 here very briefly. The first one is whose voices are heard around the table, be that in a variety of experts from different disciplines, behavioural science, social science and so on, but also in terms of groups representing the public health workforce, healthcare workforce, and also those that can represent different groups, people with disabilities, learning disabilities, different communities, cultural communities and so on, can be important, particularly when we think about compliance, messaging and so on, and what's appropriate and enactable upon for different groups. Secondly, we've talked a little bit about this in terms of a health impact assessment, a health inequalities impact assessment in terms of the sort of interventions that you would put in place, which would then help think through then what mitigations you might need to enable compliance and for everyone to benefit as much as possible. And then thirdly, I've also talked about some of the limitations of the data system that we have in the UK in terms of collecting data on health inequalities in order to find out who might be vulnerable, which communities as well as individuals might be vulnerable. I hope that by doing this we'll be able to mitigate, minimise any inequalities in future pandemics. Thanks.
Thank you. My Lord, Professor Heyman, Professor Gupta, Professor Woolhouse, Professor Bamber, a word of thanks from me on behalf of the inquiry, or the inquiry staff I should say, my Lord. With that, my Lord, I think we can draw the round-table to an end.
We can. I, of course, must thank you all as well. And I thank you on behalf of the inquiry. I have found this utterly stimulating. I can truthfully say that I've enjoyed the last 2 days. It's been like sitting watching an interesting television programmes. And since I actually don't watch television, that's saying something quite high. But I have enjoyed it. I'm sure the evidence that you have provided to us, the information you've provided us, will be helpful. in shaping our report and the discussions which will lead to our report. So I'm very grateful for all the work they've put into it and the time you've given up to come here and participate. Thank you. I can say, a trailer, an advert now, we come back, you don't, you're replaced, cancelled tomorrow, but I come back with the team and we're having another roundtable session, exactly the same format, over the next 2 days about the ethical dimension, which I'm looking forward to as well. If it's as good as this one has been, I'll enjoy myself. Thank you all very much indeed. We'll adjourn now.